Hi, this is Alicia Bright again. Now we're going to apply the concept of gas exchange to asthma. Asthma is an intermittent disease. It's considered a chronic disease. Some people acquire it in childhood and then grow out of it, and other people acquire it in adulthood. It's uh, characterized by recurrent episodes of chest tightness, wheezing, breathlessness, coughing. Uh, Asthma attacks are often caused by triggers. This is a picture of a sort of a diagram of the cascade of events that results in someone having severe difficulty breathing, up to and including airway obstruction. We're going to kind of follow the process in a little bit, but this is just sort of a diagram. It starts with a trigger, and then it continues to it starts developing this inflammatory cascade. So these triggers can lead to the constriction of the bronchi and the bronchioles. They're hyper responsive. In other words, they usually they can react a little bit to air, and now they get really hyper reactive, and the airways can actually swell up. It's kind of like if you get a tickle in your nose. Sometimes you get a little bit of a tickle and then you get a sneeze and you feel congested for a moment and then it goes away. This same kind of thing happens inside the airways, except with asthma, it usually doesn't go away very quickly. So once this inflammatory inflammatory cascade is initiated, the early phase of the asthma attack includes this vascular congestion inside the lungs, swelling starts, then the mucus starts forming, thick tenacious mucus as a result of all that swelling and vascular congestion. The bronchioles spasm and make it hard to get the air in and out of the alveoli. There's a thickening of the airway walls. This is a picture of the early phase response. You can see the allergen up on the top, triggering B lymphocytes, and which are inside the body. These trigger the IgE antibodies. We're going to talk about immunology a little bit later and the immune response. But the IgE antibodies trigger mast cells. Like I said, the mast cells degranulate and cause things to start swelling up. And as you see down on the bottom there, the lining of the bronchioles actually become inflamed and start to produce mucus. The mucus, of course, is the effort of the body to wash out, if you will, foreign bodies that are in there and stop the irritation that way. But mucus can become excessive and cause difficulty getting air in and out by blocking the airways. So a later phase response, so initially you'll have that initial response, and then later during the asthma attack, 4 to 6 hours later, it doesn't always happen. It happens in about half of our patients, but it can be more severe than the early phase and last for about 24 hours. So what we want to do is in the early phase, get it under control quickly, because it can progress to late stage. And this ultimately can lead to irreversible lung damage in the form of stretching out the alveoli and ultimately remodeling the alveoli and the bronchioles that lead to them, meaning chronic damage at the tissue level. So the symptoms that are experienced, the signs and symptoms, can be explained by this picture here. You can see that the normal bronchiole on the left has a certain thickness, certain width, which is the amount of volume that the air can get in and out through. And then the picture on the right depicts the bronchiole swollen and therefore more narrow. So you can see it's harder to get air through there. The same way it's harder to breathe through a straw than it is to breathe with your mouth open, for instance. So The person is going to experience chest tightness. They might have a cough. They're going to have trouble breathing. The classic wheezing that you hear is the classic sign of asthma, is a wheezing chest. Tachypnea, of course, is breathing fast. Tachycardia is a fast heart rate. If the air is not getting in and out, the heart is going to try and beat the blood around the body, move the blood around the body faster in order to compensate getting blood to the tissues that is somewhat less oxygenated than normal. So it's going to try and make up by getting more blood there. People in this situation are often anxious. When it's hard to breathe, it triggers anxiety in people and apprehension. Status asthmaticus is the most severe form. This is something that's, when a patient is not responding to treatment, this can lead to respiratory failure. This is what kills people with asthma. And the picture here is a diagram of somebody who's being mechanically ventilated. So when you hear, actually we're hearing in the news now a lot about a ventilator shortage. So putting somebody on a ventilator requires, you can look carefully, you'll see there's a hand holding an instrument that is pulling the tongue out of the way. There's a tube, there's a blue arrow pointing at a tube that is going down through the patient's mouth and into their trachea. That's an endotracheal tube. That tube is secured in there. You can imagine it's really bad if it comes out. So we secure that tube in the patient's mouth. You'll get more of this in Med-Surg 3. And then the tube gets connected to a machine, which is a ventilator machine, and it pushes the air in and out of the body. It requires careful adjustment because they don't just work on their own. We have to adjust them carefully, both in terms of volume and rate and amount of residual pressure. And this requires 24/7 nursing and medical expertise in order to take care of somebody on a ventilator. Again, you'll get more of that in Med-Surg 3. So obviously, the aspect of gas exchange that's impaired here would be the part where the air goes in and out, which is ventilation. So what are we going to do about it? Well, first of all, we want to prevent things. So we want to control symptoms. We want to prevent acute attacks. Once somebody does have an asthma attack, the first thing we want to do is help them rest. We're going to focus our therapy on restoring alveolar ventilation. In other words, we want to open up those airways. That's the goal of treatment here. So anybody who's in respiratory distress at all will need to rest, sit up, have a position of comfort, and then we use medical care to open the airways. We can measure with a peak expiratory flow meter, which I'll show you in a minute. We'll use these to assess the severity of the asthma attack. Hopefully, we'll be able to prevent this by avoiding allergens and environmental triggers. So the peak expiratory flow rate is measured. This is the opposite of an incentive spirometer. Incentive spirometer makes you inspire, breathe in as deeply as you can. This is a peak expiratory flow rate, so this is expiratory. You want to blow out as hard and fast as you can, and this is how the patient will have this at home and they can measure how they're doing from day to day. They might also have them in the hospital. What we do is the respiratory therapist will calibrate this to the individual, and the red, yellow, and green zones will be calibrated to their individual best effort, what they should be able to do at their best, so that we now know when they get into trouble. The expiratory rate is slowed down in the yellow zone, and then in the red zone, of course, that's an emergency. Now, notice the effect of asthma is to retain oxygen. What happens is air gets trapped in the alveoli because you can't expire it. You can't breathe it out as fast as you usually would. People will breathe it in and then they breathe it out. But the breathing in is slowed, but the breathing out is really slowed, and people tend to focus on breathing in. So air can get trapped in the alveoli and stretch them. But it's not well oxygenated air because it hasn't been replaced with fresh air. They can blow some of it out, but if they don't expire completely, the air that they bring back in is not freshly oxygenated. So back to the peak flow meter. The green zone is usually 80 to 100% of someone's personal best. And the directions when they're in the green zone is keep doing what you're doing. You're in good shape. The yellow zone is usually 50 to 80% of personal best. Now we start looking for triggers. What's going on? The person's having a little trouble. We might think about adjusting medications. Hopefully, if we can get rid of the trigger, we won't have to do that. Red zone. This is 50% or less of personal best. They're getting into trouble. They need to call their healthcare provider. Medications will need to be adjusted. This is a problem. They might need to go in and be seen. So, question for you. A patient is admitted to the emergency department with a severe exacerbation of asthma. Which finding is of most concern to the nurse? So all of these things are going to be concerning, but which one do we worry about the most? Inability to speak and sweating profusely, a PaO2 of 80 and a PaCO2 of 50, the presence of inspiratory and expiratory wheezing, or a peak inspiratory flow rate at 60% of personal best. All right, let's think about this. So let's look at that blood gas because that's probably the most intimidating answer here. Your PaO2 is a little bit high, actually. PaO2 is fine, right? They're getting enough oxygen, but their PaCO2, if you notice, their PaCO2 is high. So they're not breathing out effectively. So are we worried about that? Yes. Are we worried about presence of inspiratory and expiratory wheezing? Well, we kind of expect somebody with asthma to have inspiratory and expiratory wheezing. Let's not over worry about that. Somebody can, yeah, we're worried. That means they've got asthma. But it does mean the air is still going in and out, right? If they had a silent chest, that would be more scary. Presence of wheezing, okay, it's worrisome, but it means the air is still going in and out, so we're good. Peak expiratory flow rate at 60% of personal best. Well, yeah, we're worried about that, but actually peak expiratory flow rate is in the yellow zone, right? So we're worried, but that's not a terrible sign either. We would be more worried if it was 50% or less, which is in the red zone. Answer A. If somebody is unable to speak because of breathing problems, that is a sign of impending disaster. That's really scary. If they're sweating profusely and they can't talk, they're having severe respiratory distress. That is the most concerning sign here. Anytime somebody is not able to get words out, they're in severe distress. This person needs to be attended to immediately. This would be your first priority. We would, of course, administer oxygen, but if somebody's unable to speak, we're getting medical help in there immediately. This person may need to be intubated. Some nursing diagnoses that might apply to the patient with an asthma attack include things like ineffective airway clearance, anxiety, and deficient knowledge. Deficient knowledge, of course, is applicable to most of our patients. We always want to educate our patients. So goals would include the patients might have minimal symptoms. We want, these are not outcomes, these are not objective measurable outcomes, but minimal symptoms. We want the person to be able to maintain their normal activities and to maintain greater than 80% of personal best. Wouldn't that be nice? That seems to be a duplicate slide. Okay, health promotion. We want the patient to be able to identify and avoid known triggers. So dust covers on furniture, actually damp dusting is better than using a feather duster or something that kicks the dust up in the air. Damp dust all surfaces. Um, Avoid getting cold air in their face. It can warm the air before it goes in. That often pertains to exercise-induced asthma. People with asthma need to avoid aspirin or NSAIDs because it can trigger asthma. There's just the way that it affects the inflammatory cascade. It provides pain relief, but it also increases the ability of the inflammatory cascade that triggers the mast cell degranulation and creates more stress on the lungs. So I'm going to put a little bit about asthma medications here, but respiratory drugs are going into a separate lecture. The goal is to manage based on disease severity. There are some primary drugs that include long-term bronchodilators and anti-inflammatory agents, such as steroids. And also leukotriene modifiers. Leukotriene modifiers stop the inflammatory cascade, the immune response that the body may have to triggers. So leukotriene modifiers get right out there in front and stop the reaction from happening to begin with. So those are for chronic care to prevent asthma attacks. But once somebody has an asthma attack, the things that we consider to be we call them quick relief drugs, are designed to open up the airways, relieve bronchoconstriction, relieve the cough, wheezing, and chest tightness. And these are short-acting adrenergic stimulants, anticholinergic drugs, and methylxanthines. I'll explain that a little bit more in a different lecture, but the short and sweet of it is albuterol. Albuterol is the drug you need to know when it comes to asthma. It's still sort of the thing that we use immediately to open up airways in most situations. If you learn one respiratory drug, learn albuterol. This is the last slide in this lecture. This is you don't have to memorize all of this. I just want you to take a look at the different classifications of asthma. So step 1, step 2, step 3, and step 4 are classify how often patients are having asthma attacks and how much intensive management they need. So you can see that it ranges from mild intermittent, and we've got a definition of what that is. Mild intermittent is no more than twice a week, brief attacks, usually asymptomatic. They don't take daily medications. They might use albuterol for quick relief when necessary, but it's not bad. And you can see that it gets gradually more severe until we've got down the heaviest duty thing we'll do is corticosteroids. And we're going to talk more about corticosteroids when we talk about the immune response, when we talk about Cushing's disease. But corticosteroids, that's another one you need to know. It's prednisone is the poster child for that, if you will. Prednisone's the one that we sort of model our understanding on, but there's other kinds of steroids as well. But if you learn one of them, learn prednisone. And then if you know things are like are steroids like prednisone, then you'll kind of know most of the classification. All right, to be continued.